Hello, welcome everyone. We are live. So, first, I'd like to say thank you for joining us here at Level Headed Mind, where I am a psychiatric nurse practitioner. My name is Giselle, for those who do not know me. And if you have any questions pertaining to mental health, go ahead and drop them down into the chat and I will be answering them today. The live will go for 2 hours. So around 2 o'clock is Eastern Standard Time is when we'll close, the live and finishing answering questions. If there are any questions that are unanswered, I will be picking some questions to answer in my newsletter. So if you're not already signed up to the newsletter, go ahead and sign up on the website, levelheadedmind.com. At the very bottom there, you can click to sign up for the newsletter. Okay. So, and with the newsletter, we only do that I only send it like once a month. It's not something you won't get spammed. Okay. All right. So let's begin. Okay. Nasir, does antidepressants damage kidneys on long term? Please reply. On long term. Okay. Antidepressants, in general, to my knowledge, do not cause renal failure. There are antidepressants that would be considered a little more, I don't know if I would say dangerous, but wouldn't be prescribed to someone with kidney disease, like your tricyclic antidepressants, for example, clomipramine, doxepin, and those types of antidepressants that are considered tricyclics, just because they're a little harder on the cardiovascular system with blood pressure changes, as well as heart rate variabilities can occur long term. When it comes to kidneys, to my knowledge, with antidepressants, there aren't many that I can think of off the top of my head anyway that are metabolized via renal excretion. So, or metabolized by the kidneys. It's mainly metabolized by the liver, and then you have, your as long as your liver can metabolize it properly, then you excrete it, most of it via kidneys, like urination, etc. SSRIs are typically safe. I know I had one patient who was on dialysis and she was able to take Lexapro because it wasn't, which is escitalopram, because it wasn't in dialysis, like something that dialysis would get rid of or filter out. So I got the approval from her nephrologist that was okay. I think if you are concerned because you have renal failure, to talk with your nephrologist about it and see if there are specific antidepressants that they would recommend would be safe for you. As far as I'm concerned, though, in general, the antidepressants aren't causing renal failure. All right. Thanks for your question. Hi, Laura. What are your feelings between Vraylar and Rexulti used as adjuncts for major depressive disorder? So both very good adjuncts for major depressive disorder. I don't have a lot of experience with adding these types of adjuncts for major depressive disorder. I typically do use a different approach for depression. Now, I have used, when I was in conventional medicine practice, like Abilify, for example, which Rexulti is considered the cousin of Abilify, right? So when I'm looking at these two, Vraylar, I have a lot more experience with bipolar patients. And when I was in community health, when Vraylar first came out, Vraylar was being prescribed, and I prescribed it to a lot of my patients with bipolar, and it was very helpful. If I'm going to choose one or the other for a patient who has major depression, where nutritional psychiatry, looking at root cause and doing the methods that I do for treating patients aren't as fruitful as I'd like them to be, and I'm considering an adjunct, and I'm looking at these two, what I would be thinking is the person's weight, because Vraylar is going to have less incidence of weight gain for sure. The other thing would be the potential, like, are they having a lot of anxiety already? Because in my experience using Vraylar with bipolar patients, it often can lead to akathisia. And though with major depressive disorder, I most likely wouldn't have to go up to 3 milligrams, where I saw that akathisia be more present, it would still be something I would be considering and thinking about. So those are the things that I would think about together. I mean, you still have a risk of akathisia with Rexulti, not as high as Abilify, and I don't know the percentages up against Vraylar. So that would be something perhaps I could do in a video and look at the two and compare them together and present that as a, one versus the other, so that we can get the clear percentages of the risks of, I know for sure weight gain is a lot less, for sure. As far as akathisia, I'm not sure those percentages to say whether or not, but I do know Rexulti still carries that risk, even though I know it's less than the Abilify. I hope that answered your question. Okay, Rohit Thakur. Hello, Rohit. Which is a more safest antipsychotic in diabetes for schizophrenia, between lorazepam or aripiprazole? So when we're talking about diabetes and antipsychotics, the main thing we want to look at, as far as, I wouldn't say that they would be safer, but as far as weight gain goes and the metabolic syndrome goes, so there's going to be a less risk of that. So when we're looking at someone with diabetes, so between these two, lorazepam, because lorazepam actually has studies to show that you can lose weight on lorazepam, though it's not robust loss of weight. It's like a pound, maybe 3 pounds or something of that nature. Whereas Abilify, a lot of patients will gain weight. Now, it's not meaning that every patient gains weight on aripiprazole or Abilify, but a large percentage will gain weight. So lorazepam is one that it does not have that as a risk factor and would be, quote unquote, safer. However, with all antipsychotics, there is still the risk of the metabolic syndrome aspect of, like, increasing triglycerides and lipids and things of that nature long term. So always something to be monitoring. However, with lorazepam, you're going to have a lower risk, and utilizing things like exercise, to help with those adverse effects, you're going to get more benefit with the lorazepam than with Abilify. If you're one of those, like, I want to say the percentage is like around 30 to 40% of patients who on Abilify are gaining weight. So it's going to be harder for you, if you're doing the exercise and eating well, to lower that risk on Abilify versus lorazepam. Okay. Jiminade, I like that. Hi, Jiminade. Hey, I love your content. It's been very helpful to me on my journey. Thank you. What are your thoughts on Wellbutrin and Boost Bar together? I've been taking this combo for 15 days now. Thanks. Well, this combination can be very effective for someone with depression and anxiety, but also you can leverage with Boron in someone who has depression, the dopamine aspect of it. Boron has a downstream effect in, like, a weaker dopamine inhibition, where you can actually increase and allow for more dopamine to be available in the synapses. And so therefore, combining something like Boron with Wellbutrin can enhance that effect. And if you're someone who on Wellbutrin, you are feeling really well, but you've started to have some anxiety, because Boron is an anxiolytic, and it actually also has partial serotonin agonism, it can help mitigate those effects or lessen those effects of the increase in anxiety. Now, what I have seen in using this combination, so there's always like a but, or however, to say after this, is that some patients can be very sensitive to this dopamine influx or fluctuation, and can actually have paradoxical effect, and it can create more anxiety, perhaps even akathisia. So though there is this combination, like looking at, wow, like we can put these two together and get a very beneficial effect for someone who's depressed, maybe lack of motivation and has some underlying anxiety. There is a side to using something like this, with both of these medications singularly or now in combination, where you can risk something like an akathisia, which is that internal restlessness, and having like a paradoxical effect because of that increase, especially if you're sensitive to dopamine, or even if perhaps your DRD or dopamine 2 receptor genes, are maybe already a little overactive. So that is just something to be thinking about and considering with medications that act on dopamine in part, because Wellbutrin is also norepinephrine. It's not just dopamine. Okay. Hello there. Can you please talk about akathisia induced by antipsychotics and how to treat it? It is a nightmare for me. Yeah, it's a nightmare for many people with akathisia. Now, with akathisia, this is this internal restlessness. It's like an agitation, like you feel like you can't settle your body down. And what tends to happen commonly is that the person feels like they just have to keep moving. So you're pacing constantly just to help to tone the feeling of the agitation inside of your body down. Sometimes people with akathisia will also like exercise. I had a patient who said, I don't know what happened to me. I just like felt like I had to do push-ups. Like I had to just start, doing these bursts of exercises to get this energy out of me. And she was experiencing akathisia. So it's basically this internal restlessness, agitation that makes you feel like you just have to be moving. You have to do something. Now, when it comes to treating this, best thing to do is to start tapering off of your antipsychotic that is causing this and switch to one that would have less of a risk of this and be maybe a little more calming for you. Okay. What that would be, I can't tell you for sure, because all of the antipsychotics have this risk. Okay. Now, the other thing, when I'm working with patients, I'm looking at whole health and what underlying, like, is antipsychotic, is that really the best treatment for you? So looking at your nutrient deficiencies, doing the lab testing. I have a video on the labs for mental health, the basic labs for mental health, where I go over why I order these different labs. And this is just where I start, but it's a good start because if you're having issues with depression or even schizophrenia, there's a patient I had who had significant schizophrenia, was on multiple medications, had a vitamin D level of 11. So getting that vitamin D back to normal allowed his providers to lower the antipsychotic. So I was working with him in a coaching perspective, and he had his own providers, and he was in a different state, but they were able to, because the symptoms started improving, to lower his antipsychotic. So oftentimes that could be it. There could be some nutrient deficiencies going on. It could be some thyroid issues going on and thyroid dysregulation. So before going on the path of jumping to medications like antipsychotics, or even going down the path of needing more and more and more, which can lead to these types of adverse effects, I always advise that you look for potential underlying root causes and resolve those, because it's amazing what you could find that could actually be someone's root cause. And if you don't look, they're going to get labeled treatment resistant and get put on all of these medications. And oftentimes it's those people that have the reactions that are very, very sensitive to these medications and will say, I don't know, I've tried all the antidepressants, and then they started adding antipsychotics. It didn't work. I just keep getting the adverse effects. That could be because they have something underlying that is actually really their root cause. And these medications are just really wreaking havoc in their nervous system. It could also be because they have metabolism errors of metabolism, genetically speaking, where they're maybe a slow metabolizer and they're holding on to the medication longer, which accumulates in the body and can lead to these adverse types of effects. So definitely those are things that pop in my mind to want to look for when I'm thinking of someone who's having these types of reactions to medications, and lessening that burden, lowering the medication to help decrease that effect. Some patients can taper off and then be off and be good, and that's ideal. Some need a little bit, like when we're talking about someone with schizophrenia. However, I have heard of patients treating it with like the ketogenic diet and things like that. But all in all, always look for that. Look for your root causes, get your labs done, make sure you're looking for these things, make sure your lifestyle, you're starting to change things to help better your lifestyle, like improving your sleep. Exercise is important. No one likes to hear these things, but this is like foundational to mental health. You can't have good mental health without good physical health, and the vice versa is true. You can't have good health without good mental health. So they go together. We have a neck, and we just can't, like, say, okay, chop ourselves and look at the brain and say, what's going on in here? Really, it's connected. It's all connected. And so we have to consider that. If you're talking to someone in conventional medicine, just to kind of throw this in there for you, what they're going to say is give you a benzodiazepine. Let's just throw more medication in there. And what I can tell you is that's very dangerous. That's a dangerous road to go on. I just did a whole series on, the dangers and harms of benzodiazepines. And if you're experiencing something like a akathisia with antipsychotics and they want to put you on it, it may help for a time. But over time, that in and of itself can lead to akathisia and then this benzo-induced neurological dysfunction. So I would hopefully dissuade you from going down that path and looking into the underlying mechanisms and root causes of what could be going on, looking at your genetics like a gene site or genome test, which I talked about in the last live. So if you want to look at that one, I think it was one of the first 3 or 4 questions. But definitely looking beyond that as why you're having this type of reaction or side effect versus adding more medications to quote unquote treat when you're just masking something else. I hope that was helpful. Hi, Muhammad. Good to see you again. Okay, which is the best adjunct antipsychotics with paroxetine? Yeah, like I mentioned the very first question, I have done it in community health and primarily, with these adjuncts, right? With treatment resistant medication. I did that for a couple years, with conventional, I guess you could say. And then I started transitioning into more of this holistic, nutritional based psychiatry, integrative psychiatry, right? So number one, with paroxetine, it is not my first choice of antidepressants. I don't like to use it. I try to stay away from it because though it can be very, very effective for people, it is very, very difficult to come off. And you may ask, well, why would you want to come off if you just stay on it? Well, when it comes to antidepressants, as many of you may know, as I talk about in my videos, when you're on these antidepressants long term, eventually they stop working. And then this is where you end up where, well, what can I add? And you go down this path of adding and adding and adding and adding. And then you're on 5, 6, 8, more than that medications. And it becomes unfortunate if you just stop to take a look at what could be going on biologically, or even like trauma, for instance, can wreak havoc in the body and cause all of these, obviously cause depression and anxiety. So when you start going into this adding medications, I start thinking, whoa, so because I practice differently, I'm not looking at adding anything to paroxetine. And in fact, I'm not even thinking about paroxetine as a medication I would add. So that being said, um, if I were in conventional medicine and I had someone on paroxetine, they didn't want to come off and they didn't want to hear my speech on biological mechanisms and nutritional psychiatry and things we can do to help promote mental health besides medication. They're stuck on wanting to go down this path. I would look at their symptoms to base what I would add on to that. So, meaning if they're having a lot of anxiety and that type of symptoms with their depression and I'm wanting to add an antipsychotic, I may look to adding something that's going to be maybe a little more on the sedating side, something like, Seroquel low dose, which, would be like, oh, people say Seroquel, but you really use a very small dose, even 12.5 and help people, especially if they're having insomnia. Lorazepam is one that could also be sedating, taken in the evening, can help calm, and has been shown to help with patients who have that anxiety and depression. So I would be looking at something like a lorazepam. If it's someone who's just like super low motivated, like they're bedbound and it's hard to get them up out of bed, then I'm going to be thinking Vraylar or Rexulti, like something to like stimulate them a little bit more. And of course, be watching out for that akathisia piece. So that is, so there are a lot of things to think about conventionally, but my first thing wouldn't be like, what can we add? Because that's not how I practice. My first thing would be like, what's really going on underneath? What's really happening? And like I mentioned to the person previously, getting started with labs and figuring out, at least starting with the basic labs and seeing what I can find there. And just with those basic labs that I talk about, you can find a lot. And for instance, I just like yesterday had to call a patient because they were in iron overload, like numbers that I hadn't seen before with iron overload, in the thousands. And this person was significantly depressed, significantly low energy, and having pain in his joints, particularly in his knuckles. He thought it was because he was trying to exercise and do the things, right? And his provider referred him to me to see if there could be something else going on because he was going down this path of adding more. He tried Rexulti. He even tried like Vyvanse, I think, and Adderall and, all the SSRIs and all these things. And everything was just not working. Side effects all the time, made him worse. Nothing was helping. So bottom line, we do my basic lab set, it's called an iron panel. So it's looking at your total iron binding capacity. It's looking at your total serum iron. It's looking at your percent of transferrin saturation. And then it's looking at ferritin. And then with iron overload, you also end up with like liver enzymes that become elevated. He had all of that, all the hallmarks. So I called him and said, look, you need to see a hematologist because this is what's happening. This is what's causing your symptoms of mental health. Depression primarily can also cause anxiety, but it's just an example of finding something like that where no one else was looking, and figuring out like, oh my gosh, this is the guy's root cause. And if we just kept going down that path of give you medication, I think he was even considering TMS, like all these treatments when it was iron overload, where he's going to see a hematologist, but most likely he has hemochromatosis where they're going to just, he'll just need blood to give blood, to give, his blood, donate blood every maybe 3 months, 4 months for the first year, and then every 6 months for maintenance or something like that. But very simple, treatment. The treatment isn't an antidepressant. It's not an antipsychotic. So I'm sorry I get on my soapbox with these things, but that's what I'm talking about. And I have example after example. That was just the most recent one yesterday that stuck in my mind, that I thought was so profound, and I don't know. I just feel like we as psychiatric providers, we see patients coming to us with mental health symptoms and we're taught to just check symptoms off and then give a pill. And in reality, this DSM, though this is the desk reference, a smaller version of it, but and they have the other one, um, the DSM-5, but revised anyhow. And even in that one, they talk about, in the criteria that we need to rule out medical conditions. So if we're not ruling that out, we're not really doing the DSM justice. And because we're just looking at the symptoms and then giving a medication. But we have to look outside of that model and rule out root causes first. But so I know that was a long answer to your question, but I think that it's important to stress that, because conventional medication is not what I do anymore. And it's because I noticed that we are unfortunately causing more harm to our patients when we go down that path. Hi, Karen. Miss Karen, is EMDR successful for complete complex PTSD as it is with PTSD? You know what? EMDR is not something that I specialize in, but I work with practitioners who provide, this service and are certified in EMDR, and they work with patients of not only acute PTSD, but I would have to say most of their patients are probably the complex PTSD cases, at least the ones I refer to them. And with complex PTSD, so just so people who may not be familiar with that term, it's when you have multiple, let's say, childhood adverse events or multiple traumas that it could be considered mini traumas, right? It could be a big trauma and then you add mini traumas to it, but it's basically someone who has experienced a lot of traumas, adversities in their life, and it creates a symptomology that unfortunately looks very similar to like a borderline personality, because you've got the emotional dysregulation component. It becomes you have the risky behavior, the impulsivity, and things of that nature, where people will start to say, "Oh, this person is borderline," when in fact it's really the complex PTSD. There's a lot more to it too, but basically, so acute PTSD is what people often think about with PTSD. Like there was, a victim of a very big traumatic event. Someone just came from war, and they are hypervigilant. They hear sounds. They start having flashbacks. They're having nightmares and those kinds of things. And that can happen in complex PTSD, not as acutely, but it can be part of the symptomology with nightmares and having memories and things of that nature. So when we're looking at EMDR, yes, EMDR can be very helpful and very successful in both, because I've had patients with both, and EMDR has been very, very, very helpful. Um, what I see about it, with the patients, is that they start to be able to talk more about the traumas and not be reactive, not have uh, the shut either be reactive and hypervigilant or shut down, because that could also be part of it, especially with complex PTSD, where you're more in the fawning phase and or the freeze state, with that, and your nervous system is basically shut down, and that could be looked at as, oh, this person just has major depressive disorder, when it's really the freeze state of someone with complex PTSD. But yeah, EMDR can be very helpful to get someone out of that. Somatic therapy also very helpful, in particular with someone in freeze. Somatic therapy can also be very helpful. And so it's what I find, it's not just the EMDR, because when I work with patients, I teach them about vagus nerve and help them with the, activating vagus nerve and getting less out of sympathetic to help the parasympathetic. And also, always advise that they read The Body Keeps the Score by Bessel van der Kolk. And because it gives you a lot of insight into how your nervous system, your body as a whole, and you can see that with people who do have more of the complex PTSD, in the long run, you end up with a lot of these comorbidities. And it's because they're doing more research, on and on, years after years, but they're finding more correlation with trauma and heart disease, trauma and diabetes, trauma and inflammation, chronic disease, etc. And so when trauma is stored in the nervous system in that way, and you've got a lot of inflammation, somatic therapies can also be very helpful. There are actually people who specialize in somatic therapy, and one that I particularly like is yoga like movements, yoga for trauma. And to you can actually try this for free on YouTube. There are a couple, like yoga with Adrienne she has a whole playlist for like yoga for mental health, and she has some with trauma. And then Sarah Beth Yoga, she has some specific yoga for trauma. And I think she also has a book, Trauma Alchemy, which talks about how these somatic therapies work in relieving trauma. So I would say, definitely EMDR is going to be helpful, but to get some of that out of the body, like combining it with something like somatic therapy, would be wonderful. And you would feel so much better for sure. Tambury. Hi, Tambury. You're currently on a low dose of Paxil. Will I still experience the horrible withdrawal symptoms when deciding to discontinue? So if you're saying low dose, I imagine you're probably on 10 or 20 milligrams of Paxil. The thing about it is, the lower the dose, the less it is true, the less incidence of that, when you come to withdraw. However, what I have to say is, if you've been on it for a very long time, neuroadaptation will still occur. And so you will still have to be careful jumping off, like say from 10 to 0 or 20 to 10. That's a big jump. And so the thing with Paxil is that they do provide, you can get it in liquid form. It doesn't have to be specially compounded, which is great, because a lot of other antidepressants, you have to specially compound them. But with Paxil, you can get it in liquid form. And I would say to do, as far as the reduction, to not, go from 10 to nothing, or 20, to 10, that's 50%. That's a lot. So maybe 10% reduction or something, like that. Now, when we're thinking of the receptor occupancy with the neuroadaptation that occurs, when you get to the lowest dose is when you have to be the most careful when you're coming off. So someone who talks about it in their book, I actually have it here, Dr. Horowitz and David Taylor, they wrote the Maudsley Deprescribing Guide, just came out this year, March of this year. Very, very good book that actually has tables, and it has different tapering schedules. So if you do end up running into trouble, I would get this book and then use their guidance, use the guidance that's outlined there, because it's very, very thorough. And like I said, with Paxil, though it can cause these horrible withdrawals, it does come in liquid form, so it wouldn't be challenging to do that type of a taper if you needed it. Den G, hello Den. Hello, I am on Depakote and Ceroax. I'm not sure what that one is. And I am better. I was on olanzapine too, but my doctor take that off because I was dizzy and sleepy. Okay, I was on Wellbutrin, but Wellbutrin made me worse and it caused me depression. Can antidepressant cause depression? Paradoxically, more depression. Okay. Paradoxically speaking, like the guy I was telling you about earlier that I had to call yesterday with iron overload, the antidepressants were causing more depression. Okay. And what conventional doctors would say is, oh, that's a paradoxical effect. Like, let's get you on, let's try a different antidepressant. Like, let's do a gene site test. Let's do which is all fine. But if you have something medically going on and you're just masking it, You may feel better for a little bit, or you just may keep feeling worse and worse and worse and worse and more depressed and more tired and more, whatever your symptoms are. So with Wellbutrin, typically, no, you don't feel more depressed. By and large, most people are going to feel quite the opposite because it's norepinephrine and dopamine. You're going to feel this, wow, like this energy, this motivation. I can do things. I can, actually like get around, and I feel so much better. I feel like I'm out of this depression. If, however, you're feeling like it's making your depression worse, that's completely opposite of what it's doing. So that's when I start really thinking, what is going on under the hood? Let's get then some labs. Let's look at nutrient deficiencies. Let's look at thyroid function. I've found a lot of people with Hashimoto's where they had the same pattern. They're feeling worse. They're not better. They keep adding more and more. And it's Hashimoto's, it's a thyroid condition. Of course they're going to feel worse. So definitely looking into that. And then, like I said before, the gene site or genome mind, those pathways aren't bad, like meaning, that would be another thing I would be thinking of, especially if I did the labs and I'm not really seeing a smoking gun or seeing like what's causing it. I would start thinking like, well, maybe there's something going on with their CYP, 2D6 or 2B6 when it comes to Wellbutrin, like maybe there's something going on there where they're just having maybe too rapid of metabolism where it's not helping and their depression is just getting worse or something of that nature. So looking at those things, what's going on root cause wise, nutrient deficiencies. I already mentioned iron, thyroid, vitamin D, B12, folate. Those are all ones I think about when I think of depression and depression getting worse. Then even some inflammation markers, autoimmune conditions can also definitely first signs depression for a lot of those. And then looking at a gene site or a genome test and figuring out if there could be something going on there genetically. Maybe you're not metabolizing these medications well. Okay. Ganesh, hello Ganesh. My psychiatrist prescribed methylphenidate 1 year ago and I took for 1 day. Helped me. After that, I never took because I never needed. Now my exams are coming, but methylphenidate didn't help me. This now, please explain the reason why they aren't working. So why methylphenidate isn't working anymore, and it did work. Well, with any medication, there's that risk of the, like I talked about, the neuroadaptation. It happens with all, and it's not just psychotropic medications. It's not just the medications for mental health, the stimulants, the antidepressants, antipsychotics. It can happen with a lot of other medications too, where you're on a medication for a while and you just become adapted to it physiologically. We call this neuroadaptation when it's happening in the brain and we're flushing the brain with a lot of dopamine, right? Eventually you become less receptive to that influx because it becomes the norm. You're resetting your homeostatic set point, meaning you're resetting what is normal in the brain by adding in a medication like this. And which is why I always tell my patients on, especially these medications, because you don't have to take them every day. I say take them when needed, try to take the holidays off, like meaning, when you're not in school, take a break. When you don't need them on the weekend, take a break. To help reduce this as a potential adverse outcome that can occur. So that is most likely why. Now, you could have something going on genetically where maybe you will respond more to amphetamines. I'm not sure, but that's something you could explore as well. But if it worked before and it worked fairly well, and then it's not working now, I would say it's most likely having to do with that. But sometimes, we will switch, to something like a different type of stimulant medication, like going from, methylphenidates to something like amphetamines as a switch. But again, like I been saying all along, I would also be curious to see if you had low vitamin D, low omegas. Oh my gosh, that's one thing I've been finding most recently too, with people who say I had brain fog, low concentration, and their omega index is 1%. It's insane, and that's very, very low. For optimal brain health, we really want it above 8. I think Quest Lab says above 5 or 6 or something like that, but optimally, you really want it to be above 8%. And so definitely I would be looking at those factors. Zinc as well would be another one I look at when I'm looking at someone who has, an ADHD diagnosis, and they want to look and explore potential underlying causes. So I really dive deep into the nutrients and trying to figure out if this could be nutrition related. It could also be for some people because they have an intolerance to gluten or dairy, or that's just the way their body's responding to those. It's causing a lot of neuroinflammation. And so it's not as evident because they'll say, well, yeah, I don't get like my stomach doesn't get bloated, or I don't get like upset stomach when I eat these things. But if you are really monitoring it and tracking your mood along with what you're eating, you can uncover it that way. There are tests you can do to see if you have sensitivities. And I'm not talking about celiac disease. I'm just talking about like a sensitivity where it's actually causing you to have more inflammation in your body. So like a food sensitivity test could tell you that. They are, expensive, usually running, anywhere from $400 to $500 for a decent test. But like I said, if you just are good at tracking your what you're eating and then tracking your mood and how you're feeling, you can uncover some of these things as well. And if you've like changed your diet, perhaps, that could be some of the cause for why it's not working. So thinking outside the box in that way is also useful. And of course, something that I would do and I would go to first before trying to switch a medication. Hello, Muhammad. Is the correct dose of 150 milligrams XR quetiapine with fluoxetine, 20 milligrams for bipolar? You suggest this type of combo? Yes. Yeah. So 150 milligrams XR quetiapine can be used in and of itself for bipolar. You can adjunct with fluoxetine, 20 milligrams. That's Prozac. So you could do that. Have I used this combination before? I can't think off the top of my head. I know for sure as a singular agent, the XR of quetiapine has been very helpful for bipolar patients. And yeah, I have used the XR by itself. And sometimes you may need to add something like an antidepressant low dose, but always with caution with bipolar because of the switch to mania that can happen. And I believe we've talked about this before with when you had asked me about type 3 bipolar, which is cyclothymia, because I looked into that. It is what we call cyclothymia. But yeah, you just have to be careful with someone with bipolar 1. And a bipolar 1 patient is really where I would want to use like an XR quetiapine as a single dose, like, depending on if other things weren't helpful or if they have like significant mania and they're not sleeping and they really need to sleep. That's what pops in my mind. And then once we get them stable, we can transition them to something else just because of the long-term effects of Seroquel or quetiapine, metabolically speaking, with weight gain and if it's needed long-term, oftentimes does lead to that metabolic syndrome and the pre-diabetic state and et cetera. So, but yeah, I mean, this combination can theoretically be used, and you would just want to make sure you're monitoring them for the adverse effects of number one, mania, and then metabolic syndrome, and of course, making sure they don't have any of the movement type disorders like the tardive dyskinesias and the Parkinsonism like extrapyramidal symptoms. So be monitoring for those as well. But Theoretically, yes, it could be used. Mhm. I love your content. It's really worth it. Thank you so much. Very nice. Um, Chantal Singh, um, Shantanu Singh. Sorry if I'm pronouncing names wrong. Yeah, I'm sorry. All right. Which antidepressant should be used with Desvenlafaxine in major depressive disorder or when symptoms of depression are not going? Um, with Desvenlafaxine. Yeah, that's Prestige. Okay. I have a video about Prestige and venlafaxine. These two are I say that they're the worst, though they can help people, and I know that they can help people. Um, but they're just really hard to come off of when they stop working or when you want to switch to something else. They could cause some really bad brain zaps and really bad withdrawals. So we got to be careful. So if I'm going to switch, when it comes to switching antidepressants, I've got to, see and look at what you've been on, what your primary symptoms are, like what are we trying to target before, thinking of the switch and then doing it very carefully. Now, switchrx.com has, you can tell your provider if they're not sure about switching, like how to switch someone, and they'll go week to week. Sometimes I'll go a little slower than that, depending on like with something like Desvenlafaxine or venlafaxine with the crossover, just to make sure we're not doing it too fast and causing these types of issues. But typically you could do that like week to week if you're going to cross over and be okay. Now, the thing that, like I said, that where I would be looking at which antidepressants, if you've already been down the path of SSRIs, now you're moved on to SNRIs, conventional psychiatry would talk about adjuncts or maybe even a tricyclic or, MAOIs, which have their own burdens and high risk. So, those would be conventional medicine practices, switching to something else or adding something else. But like I keep saying, before doing that, please look for a root cause, look for something else that could be going on. And if you're not in therapy, get in therapy. I haven't mentioned that. I touched on it with the EMDR stuff with trauma, but therapy can be very, very effective for people who got started on antidepressants because of a life stressor. Someone died, they became depressed, and then they just got stuck on antidepressants the rest of their life. That's not what should have been first line treatment. It should have been therapy, grief therapy, to help with that, because it teaches you to rely on a pill when you're dealing with normal life things. So depression, these emotions are part of our normal experience as human beings. We pathologize them because it's like, I just need to we have this culture where we have to get through our day. We have to work. We have to be productive. There are no mental health days. I can't take a few days off and reset myself. I can't afford to take vacation. I'm on the go, go, go. Maybe I'm a single mom. Maybe, with whatever the pressures are of society. So when we feel a little down because of life, which is normal, we want a quick fix because we can't afford to be down. We can't afford to take the time to fix ourselves. And that's created this, culture of pill for every ill type of a thing, which I am against. So though I do recognize that there can be a chronic depression that's debilitating, that meets the criteria for a diagnosis, I also want to look and make sure that we're not masking something else. Looking at thyroid, looking at nutrients, looking at, all those minerals, the cofactors for serotonin synthesis. Sometimes that's what's wrong with you. So because adjunct with those types of things, when you start adding in, like you start fixing their nutrient deficiencies, that's why Deplin, which is a methylfolate, works for so many people because you're actually treating this deficiency of like someone who has a low folate level, and you're fixing that cycle or that pathway of how your body makes your neurotransmitters. You're fixing the methylation cycle. So there's something going on in their methylation cycle. And a lot of people have this or have depression. So looking at those kinds of things, I have a video that talks about the MTHFR, and that's one of the genes that responsible for methylating folic acid and breaking that down into methylfolate. And as part of that cycle, that you want to make methionine instead of homocysteine, which can be inflammatory and lead to all kinds of neurological problems and cardiovascular problems as well down the road, etc. So yeah, so when you're talking about an antidepressant, it's not working and you want to switch to something else, first think, did you really do the due diligence, or did your provider really look at what's going on under the hood? Are there other things you can be leveraging to help your symptoms? Should you be in therapy? I would say yes. I tell my patients, you should really be in therapy and not just relying on medications, for sure. Because oftentimes there is definitely a component of the way you are thinking. And in general, we all think, they've done studies where they say 80 to 90% of your thoughts are negative. That's crazy, right? But that just tells us that we need to do the work to reframe our thinking and get out of that negative mindset and get into more of a positive mindset, which helps us get into a healing mindset, which is understated in and underrepresented in our research in mental health, and not emphasized enough when it comes to treatments for mental health symptoms. Hello, Barbara. Can I use Xanax at a low dose long term? Xanax is the only thing that works for me for anxiety. Yeah, well, of course, there are people that do. I say do it with caution, because even if it's a low dose, there is on the Benzo Information Coalition webpage. I think benzoreform.org has a article about this too. But this whole thought of it's just a low dose. It's just, 0.25 of Xanax. That's a tiny dose, isn't it? Well, people still get injured and benzo-induced neurological dysfunction on just a low dose. It was the unfortunate thing that happened to Dr. Christine Huff, who passed away not too long ago. She was on Xanax, and I'm pretty sure her dose that she was on was 0.25. And she was trying to taper off of that and struggled immensely, and unfortunately passed away a few months ago. So it's not a guarantee that just because you're on a low dose, you're not going to end up in this position of eventually tolerance, needing more. And then if you don't do more, and so you go one of two ways. You realize that, oh, it's not working anymore. It was working great, for however long, and then all of a sudden it stops. So you can go down the path of needing more and more and more. Or say, well, wait a minute. I've heard about this. I've heard about this happening where I need more and more. And I, you know what? I don't really want to go down that path. So I'm going to start trying to come off of it. So either path you choose, you risk the benzo-induced neurological dysfunction, which I did talk about in my last video, and people refer to it as hell on earth. And I see people day in and day out where, even when we are doing the nutrient things, when we're replacing when you're already injured, going through that, it's like being tried in the fire, and I always tell people though, when they are going through something like that, I believe it is a refinement process for whatever reason. I am Christian by faith, so I think of it as, maybe it's a trial of your faith kind of a thing, but people do come out of it, so it's not all doom and gloom. But when you're in the midst of it, it feels like you're never going to get through. And because it oftentimes is long lasting, a year, 2 years before someone does come out. But when they do come out at the other side, and I see people come out the other side, it's amazing the transformation that does happen, but it's not an easy transformation by any stretch of the means, and people do struggle immensely. So though Xanax is working for you for your anxiety, I'm glad you have something that's working. Um, and if you're not in that bind state, if you're not, I would want to say, hey, docs, can we start looking at other issues that could be causing my anxiety? Can we look at optimizing my magnesium levels, perhaps? Oftentimes with anxiety, it could be something like that. It could be MTHFR, finding lots of that, which means you have an elevated homocysteine for anxiety. It could be, again, with the pattern of thinking, how you're thinking. Have you done therapy? Have you been working with someone who knows perhaps cognitive behavior therapy or acceptance and commitment therapy? Very good for anxiety, to learn how to sit with your emotions and allow them to pass through. Like I mentioned earlier, these symptoms that we pathologize are part of the human experience. Like, you're not going to get rid of anxiety. It's definitely something that we all have to live with every day because it's part of our survival mechanism. We have to understand and be aware of threats in our environment, but it's when it becomes dysregulated in your nervous system for whatever reason, which could be a whole list of things. Like I mentioned, with MTHFR, homocysteine could be the cause of all of that in that video. It could also be other things like hyperthyroidism. It could be, issues with not just magnesium, but zinc and copper ratio. What does that look like? Maybe you have too much copper, too low zinc. That could lead to irritability, anxiety, those types of symptoms. And like I just mentioned, just inflammation, some autoimmune conditions, the too much iron or too low iron. Most of the time that looks like depression mixed with anxiety. But all of these things, really need to be looked at further before, because if you went down the whole path of SSRIs and all, which I'm guessing you did because it's the only thing that works for you, that always clues me into there's something else going on. There's something else underneath going on. This isn't a Xanax deficiency. This is something else happening. So making sure that you're looking for that before, you end up becoming one of those statistics, 20% of patients long-term use, it doesn't matter what dose, end up with benzo-induced neurological dysfunction. So, can be significant. Rohit, hello again. I was taking 2.5 milligrams aripiprazole daily, the risk of diabetes. Yes. Long term. It's a long term, not a short term. So this is the same thing like the other question she was asking me, because that's a low dose of Abilify. And again, people think low dose, is it better? Well, what they found with antipsychotics as well is that there's still a risk for metabolic syndrome. You're definitely lessen the risk of akathisia. You definitely lessen the risk of those types of symptoms, like extrapyramidal type symptoms, movement disorders, the tardive dyskinesias, the pill rolling, those types of things. They call them extrapyramidal symptoms, or EPS. Minimize that with low dose antipsychotics big time. So safer in that regards. But when it comes to the risk of diabetes, it may take longer. So if you're on it this is like a long-term thing, years and years and years down the road, but it can still, unfortunately end up increasing your lipids, your hemoglobin A1C, those types of lab values, that what they consider the metabolic syndrome and the pre-diabetic state, which can then turn into a diabetes. So so basically, just like with the benzos, it doesn't matter what dose, there's still this risk, for in your case, the metabolic syndrome or pre-diabetic state. Hello, Muhammad. Can lithium use cause permanent thyroid malfunction. So lithium carbonate, which is pharmaceutical grade lithium, and oftentimes it's used in high dosages, right? So you have to monitor your lithium levels. And even if you're monitoring your lithium levels and you are being astute with that and staying within the therapeutic index of what is not considered toxic with your lithium levels, you can still end up with kidney damage and or thyroid damage. So, and you're still not in a therapeutic range. Well, the other thing is, okay, so there's, when you're looking at lithium, some people do need really high dosages of lithium, but what I have to say, and this is mostly for someone bipolar, okay, it can be used adjunctly for schizophrenia. But when you're treating a bipolar one person with lithium, and you're trying to get them in a therapeutic range, you also, you don't want to focus, and they teach us this in school, so this isn't like, just my theory, but you also want to look at the main thing isn't so much the therapeutic range, it's making sure you don't go toxic, but you're looking at someone's symptoms. So this is where you have to you can't just look at the paper in front of you and say, oh, they're not in therapeutic range, let's just keep increasing it, because some people, which is, like nutritional lithium, you never get a lithium level because it's so low. Okay. Lithium orotate, nutritional lithium. You won't measure a lithium level, and you won't find a lithium level in someone with nutritional lithium until you get beyond 40 milligrams. And even then, it's very low. Okay. But very effective for treating people with, depression and even Alzheimer's and some bipolar, more bipolar 2 though, and not so much bipolar 1. If you're finding that you need more than that 40 milligrams of lithium orotate, you do end up having to switch to the carbonate, which are these higher dosages that you're talking about, but you have to be careful. So if you're saying you're not in a therapeutic range and you're still not feeling better and you still feel like you need to go higher, yes, sometimes you do need to go higher than 1200 milligrams. Yes, 1500, 2000, sometimes you do need those high dosages. But make sure that you're definitely, and I'm sure your providers are checking your levels quite frequently until you do start feeling better. And some people, like I said, feel better and they're not in that therapeutic range, but they feel better, and that's fine. You don't have to get to that therapeutic range. But if you're not in the therapeutic range and you're not feeling better, like your symptoms aren't being alleviated, then you technically can keep, increasing your dose as long as they're checking and seeing. Now, like I said, higher dose, long-term over time, though lithium carbonate, very effective for treating bipolar and is considered the gold standard in bipolar treatment, does have that side where it can start causing, problems with thyroid, causing a hypothyroid state, leading to kidney damage and kidney failure over time, which is why even when you are at a therapeutic state, like you're feeling good and you're on a dose that's helping you, your doctors are still going to at least do every 6 months blood work just to make sure they're looking at those other markers as well, to make sure that we're not going into that area. Now, there are some with lithium orotate, and Dr. Greenblatt, I'll show his book because I have it. Here's one of the other books I keep by me because I love it. The Cinderella story of nutritional lithium, Dr. Greenblatt. He has a page dedicated to nutritional lithium. And Rahul, I think you may have, I might have put that as a link in one of our sources that I mentioned. We can put the link there so they can look at that and read. He has cites lots of studies and research on nutritional lithium, but basically how it can be very beneficial for treating a whole spectrum of these mental health conditions, but also when adding in things like omega-3s and adding in your minerals like zinc, and things of that nature, that you can actually help prevent these long-term effects or prevent issues down the road with omega-3, with the lithium. So adding in like omega-3s and maybe just a multivitamin that has some zinc in it, a good multivitamin, multimineral, could be very, very helpful. And when I say adding in omega-3s, you want to be in the 2 to 3,000 milligram range. So it is a high dose, which, because most people, when they substitute, like they start taking omegas, they're only maybe taking 1,000, maybe 1,500. They're not taking that high. But when it comes to helping with brain health, inflammation, and helping to the overall protective mechanisms of how omega-3s are, those studies are using higher dosing. So 2 to 3 milligrams, or 2,000 to 3,000 milligrams, 2 to 3 grams of omega-3s. So yeah, definitely things to consider to add. Now, with his research, it's he's looking at lithium orotate, but I do think some of the research he cites in there, especially with the adjuncts, were using carbonate, because a lot of the research is using the pharmaceutical grade. And then he does a lot of work with lithium orotate with his patients, and has that whole page, like I said, dedicated to it. And he also has free webinars that I believe are still available on lithium that would maybe benefit you to just look into it and talk to your provider about some things that you can be doing to help optimize your current needs for lithium. Okay, Den. Hello, Den. Is neurobiome good along with antidepressants? I don't know that supplement. It contains vitamins B1, B6, and B12. Well, if it contains those, okay. So those are all the vitamins that are typically included in a methylation support vitamin, along with B9, which is folate. So sometimes it's not listed as B9, it just says folate on it. But B6 and B12 in particular really help with the neuronal connections, and like, for instance, brain plasticity and things of that nature. Can be also really help with someone has a neurological injury, stroke, and things like that. These B vitamins can be very helpful. B1 is very good for when we're looking at just the brain side of things, the cognition part and helping with that, brain fog, etc. So yeah, these types of vitamins and nutrients can be used along with antidepressants. I don't know this brand, so I don't know if they're using the chemical synthetic forms, which I would advise against, like the cyanocobalamin, for instance, or like with the folic acid. So you would want to do something like, instead of folic acid, folinic acid, or methylfolate, or hydrofolate. I think it's adenohydrofolate. But staying away from like the folic acid, which is more synthetic and harder for some people to break down. And then, of course, cyanocobalamin being a having some cyanide in it, which they say it's negligible, but it's still cyanide. So using something like a hydroxycobalamin or methylcobalamin would be safer. So I would be looking at that in this supplement, making sure there aren't any fillers, and making sure they're a third-party tested company, and what they meaning what they say is in their supplement is in their supplement, and it's not contaminated with other things, because they do, those supplement companies that are third party tested are making sure that they have done, another company comes in and tests on random days, random times, just takes their supplements and starts testing to make sure that it's what they say is on the bottle and it doesn't contain any contaminants as well. So yeah, so I can't really speak for this company Neurobiome or this specific thing, but yeah, adding in B vitamins can be an adjunct. It's one that I use. Like not Neurobiome, this product, I don't know, but I mean like it's a thing that especially when I find that someone needs the nutrients, because I check for these nutrients when I'm doing their nutrient evaluations and looking at these markers, specifically homocysteine. Um, yeah, then I would add in, these B vitamins if I feel it's something that is needed, and oftentimes find benefit to the point where you can start then stopping the antidepressant, and in a safe way, you can start tapering off. John C, hello. I'm taking 0.5 milligrams for lorazepam daily for anxiety. I've been on it for 7 months. Could you suggest a slow taper schedule? Well, 7 months. Okay. Wonder if you haven't already stopped taking it. A lot of factors to consider here. It really does require like a consultation to dig into things, and then also see what else is going on before you taper. So my process in tapering, you could always get the monthly deprescribing guide that has, I think it's $35, for maybe 40 at the highest on Amazon. So it's not like a big purchase, whereas, a consultation, would be, a couple $100, $300 with me, or, other providers would charge quite a bit more. But anyway, because there's a lot of factors to consider before just saying like, oh, 7.5 milligrams lorazepam on for 7 months. What's the formula? Type it in. No. Lots of things to consider when making this decision to come up with a taper schedule. So it's not something I would do on like a live. But what I would say is that you make sure that you're accounting before you even start your taper schedule and embark on this. I always warn patients, first, do the labs. It's so important because, and the reason I say this is because every patient that has started with me before they tapered, so before an injury has happened, before they've gotten into trouble, right? Before they even consider tapering, right? And we check their labs and we replenish their nutrient needs and we give them everything they need, and then we taper. Guess what? They don't have issues. They don't have issues. Knock on wood. I haven't had anybody that we start from the beginning, we get them on. And usually I'm not even starting them on, but sometimes like a benzo, like we'll put them on for a couple of weeks, or if they've already been on one and then we want to start a taper, I say, look, let's labs, very important. And I'll get some people that, oh, no, or my doctor's done labs. I always warn you, because I guarantee you, unless they are a functional integrative psychiatrist or psychiatric nurse practitioner, they are not looking at labs with a mental health lens, and they are definitely not looking at optimal levels and how to optimize your nutrients. So I always say, I don't care if you just had labs done. Like, you need to do these labs, really, really, if you want to do it right, before embarking and starting on a taper, and make sure, because if you go and do it after the fact, because I've had people that have then done that too, where they end up saying, I made a mistake. I didn't really, do my labs, but now I want to do my labs because, I'm having a really hard time with my taper, and I'm really struggling. It's a lot harder then, because now your nervous system is very sensitive. And now when we start trying to replenish what your body needs, then it becomes very, very difficult, because your body is now overly sensitive to now supplements, nutrients. Not so much the ones that tend to be the safest, omega-3s, vitamin D, magnesium tend to be the safer ones if you find those deficient during a taper and someone's injured. But the ones that are harder are going to be like definitely the B vitamins. And if you find someone's MTHFR, that's what they need. But man, if they're already in that injured state, they're super sensitive, and it's so hard to get them to get that methylated folate into them and give them what they need. So definitely, what I would say to you is that before going on a slow taper, and I would say a slow taper would be, hyperbolically speaking, like that's what he talks about. He's looking at the receptor occupancy and going down from there. And you can get lorazepam in liquid form. And like a slow taper, for example, would be like going from 0.50 to 0.49 to 0.48, doing something like that as an example. Um, but if you didn't replete something that you've needed, right, that could have been the root cause of your anxiety to begin with, and then you start, that can trigger some of these types of, like the bind, benzo-induced neurological dysfunction, or even just like a withdrawal state that sometimes for people end up being a protracted withdrawal state later on down the road. And then it just requires more work on the back end. So I'm glad that you are looking at wanting to taper off. And if you've only been on it for 7 months, you're feeling, pretty confident about being able to taper off. You've done the labs necessary, to make sure that you've replenished all of your nutrient needs. Then I would say that, coming off of 0.5 should be relatively easy for you. Doing a slow taper, you could probably tolerate every 2 weeks, considering like saying that if you haven't been injured in the past with benzos and you haven't had an issue with, say, antidepressant withdrawal in the past, like had that history, because that would make it more risky where you would want to go probably slower. But yeah, you could probably benefit from going down, anywhere from, they say anywhere from 2 to 10% cuts, every 2 to 4 weeks, generally speaking. But you may be able to do, that higher end 10% every 2 weeks, decrease and be okay. But I wouldn't jump to doing that or try it out without first making sure I've replenished my nutrient needs and make sure that there isn't anything going on, like say a hyperthyroidism or some kind of medical condition. So the labs for mental health that I talk about in the basic labs for mental health is a starting point. So I would say, start there for sure. And then, go from there. But talk to your provider about that. Maybe you are working with a provider who understands functional and integrative psychiatry. That would be ideal. Okay. Abhishek Shehoon. Hello. Hello, ma'am. Good evening from India. Very firstly, hi. Um, I'm having burning sensation on my palm and weakness. I'm not sure if you can hear me. Okay, I think I just had like some kind of interruption there. But I think I'm back online. Okay. So burning sensation in your palm, severe weakness. Okay. This reminds me of my iron overload patient. Yeah. Um, could also be, okay. So yeah, so that reminds me because it was mainly in his hands. He had like a burning pain, the type of pain in his hands, but it was mostly like his joints and knuckles. This is more in your palm, but definitely severe weakness. And then the antidepressants aren't working. So I would be thinking of nutrient deficiencies, B12, could cause some kind of a burning, B6 as well. Deficiencies can cause like a paresthesia type of a feeling. Looking medically, autoimmune conditions. So I would definitely, that would be on my radar. So that would be where the ANA with reflex to pattern would be a good test to do. Now you're in India. I don't know all the tests that are available to you, but I would definitely be looking at doing a complete nutrient panel and ruling out nutrient deficiencies, because oftentimes that is the cause. And then autoimmune conditions that could be causing, these types of issues could, so I'd be looking at like connective tissue disease, but not specifically looking at all of those rheumatoid arthritis, looking at lupus, has weird symptoms like that. And just looking at but looking at the autoimmune marker, which is like the ANA with a reflex to titer and pattern. So it's going to tell you if your ANA is elevated, it will then automatically look for what type of pattern is being seen, which will help to guide a rheumatologist into what further testing would be required to like hone in on what else, is going on. So definitely those would be the things that I would really be curious about here, especially when I see like severe weakness. And then that iron panel would be part of the nutritional assessment. And usually if they're going to do like a micronutrient panel, it may only include ferritin, which is a good marker for like an iron deficiency. It's very sensitive for iron deficiency, and you want to definitely optimize it. But when you have severe weakness and like mainly like joint pain or like this burning pain in the hands and the joints, you're saying the palm, so it may not be that, but iron overload is the thing. So that's where you want to look at those other markers. I can do an iron panel and look at total iron binding capacity, total serum iron, along with ferritin. But ferritin would be high too, but you'd have to see it with those markers, and then also be looking at a complete metabolic panel to look at your kidney and liver function, because liver enzymes are typically elevated, and then kidney markers can start to trend in elevation over a long period of time. So it's not something you want to just ignore for sure. But none of these things you'd want to ignore long term, because they're just going to lead to more worsening of your symptoms. So definitely would be thinking of those things for sure. If this is homocysteine related, homocysteine is dealing with like the methylation of your B6, your B9, which is folate, and your B12. That's a good sensitive marker for that without having to do like a genetic test for methylation errors, like the MTHFR and MTRR and MTR, which are the other like your B12, B6, and those other vitamins that you maybe not be methylating properly. But homocysteine is primarily looking at those three, and then looking at what those levels are, you can kind of deduce what you could be struggling with that could be causing this type of a symptom. But yeah, and then looking at just general inflammation markers and looking at sed-rate, maybe interleukin 6, looking at C-reactive protein, like a high sensitivity C-reactive protein, to see what else could be going on. But definitely would require a good thorough medical workup to really see what's going on. And then I would say, I don't know if this is something in India or not, if you guys have nutritional or functional medicine providers that are looking at optimizing your nutrients. So looking at optimal levels, not just what's considered quote unquote normal, which is oftentimes subclinical anyway, like meaning, if someone has a B12 of 200, it's quote unquote normal, but you can still feel pretty crappy. And optimally you would want it above 500, 500 to 1,000, so that's just like an example. Same thing with vitamin D. You could have a vitamin D of 33 and be considered normal, but you're going to feel like crap, and you're probably going to have depression symptoms because you want to be optimally above 50 to 100. So yeah, so looking at things in that nature, it would be what I would recommend for sure. Andrew Villarreal. Hello, Andrew. I've been off of Ativan for 3 months after a 3-month taper and being on them for 14 years. Whoa. So you were on them for 14 years and did a 3-month taper. That's pretty fast. I truly don't want anything like a SSRI or a benzo for my GAD. Your thoughts? Well, okay. If you were able to get off of 3 months unscathed, that's great. When I mean unscathed, meaning you don't have any rebound symptoms or the bind, like I talk about in the video on benzo-induced neurological dysfunction, that's wonderful. Then we really, if you're just now looking at like I have generalized anxiety disorder, and a lot of that has to do with rumination and constant worry. Okay, if that's what we're talking about, and we're not talking about a bind, okay, which can happen after a 3-month taper of being on Ativan for 14 years. If we're not talking about that, With GAD, definitely cognitive behavior therapy, very helpful. Learning skills of mindfulness. I have a video that's going to be coming out on mindfulness and talking about the research behind mindfulness. But mindfulness really helps you get in the present moment and can really help people with anxiety. It doesn't mean that you have to be in a meditative state necessarily, but you can practice mindfulness and bring in present moment, just sitting here and feeling your body, doing a body scan. Doing grounding techniques is a form of mindfulness. Going on a walk, feeling how your body feels, looking, it's getting outside of your head, basically. Because with GAD, you're either stuck in the future or you're stuck in the past. Stuck with what if, what if, what if, what if, what if, what if. That's futuristic, catastrophic, oftentimes thinking. Stuck in the past, a lot of the guilt, oftentimes that's related, depression, but anxiety can also be like, oh, I didn't do this right. Or when I said that, I should have said it this way, or I should have, you're just going back and forth with the past. And so you're never really in the present. And this practice of mindfulness is intentionally bringing you back into the present so that you can get out of that pattern of thinking. And over time has been shown to have actual changes in the brain with functional MRI, with imaging. They have found that just 8 weeks of a mindfulness-based stress reduction training, that it improved areas of the brain and helped to like decrease an overactive default mode network, which is often found with anxiety to be like, off the rails. You're always, you're constantly just, like I said, future or past. You're never in the present. You have a hard time bringing thoughts in to the frontal lobe and just taking the time to say, you know what, that's just a thought. I don't have to focus on that thought. I can let it go. That's what's really hard with generalized anxiety. And that's what mindfulness allows you to do. It takes patience and it takes time. And the one thing I know about people, especially Americans, I'm American, I live in America, is that we want it now, which is where the benzos come in, right? You take that and bam, the thoughts are gone. You can just go on, right? So it takes some effort. It takes patience. It takes time. And working with a professional, definitely, I would recommend to do this type of training. Trying to embark it on your own, oftentimes people end up maybe not doing it long enough, or they do it for a couple days and then they stop. It didn't work. So you need that consistency there. And like I said, at least for 8 weeks, because that's where the research has shown where a lot of this training has been effective, is for 8 weeks, daily practices. So being intentional about that. CBT, cognitive behavior therapy, I've mentioned this before about how that can help with reframing your thoughts, get you out of that. Again, it's all about the thinking pattern, helping that. But something else that can be really helpful that I have a video that's going to be coming out on the vagus nerve. So vagus nerve is something where with anxiety can be overstimulated, oftentimes is overactive. Not the vagus nerve, but the sympathetic nervous system is overactive. And so vagal tone is very low. So you have a hard time with shutting the thoughts down because your nervous system doesn't even know how to calm itself down. The vagus nerve is just like, it's done, right? And so learning how to do vagus nerve exercises and tapping into your vagus nerve. And if you're finding benefit there, using devices like NeuroSim, which is currently available in like Europe and soon to be available in the US. That's a certified medical device you clip to the tragus of your ear that directly stimulates the vagus nerve to help basically improve vagal tone, and over time really help improve this generalized anxiety and the ruminative thinking and the worry. Also combining that with like a meditation practice or a mindfulness practice, very even more beneficial. So that's NeuroSim. soon to be available in US. But the other one that I use that is currently available in the US is Alpha Stim Aid. And you want to make sure you're getting the non-generic version. There's generic versions of these. There's generic versions of each of these devices out there, and those generic versions, unfortunately, are not regulated and they're not certified. So, and unfortunately, I had linked to an article in that video, which I'm going to be, posting soon on the vagus nerve, that talks about someone, having a heart attack and one having a stroke because of these uncertified medical devices, because the currents that they're providing, which is, it's a small micro current, like electrical current, with the vagus nerve. With the alpha stim, it's they call it neuromodulation. And with the alpha stim aid, it's micro currents, similar to like a TENS unit would have, like kind of stimulation. But if you do it incorrectly, if you're using a device that's not certified, it can cause significant issues. So, so if you're going to look this up on Google or something, just make sure you're getting the Alpha Stim Aid AID device that's certified, and Neurosym, NUROSYM. And you know what, Raul, if you can put those links to those sites, that way they don't get trapped in the Google generic black market space with these devices, so they can see. And then both of them have a page dedicated to like their research, where you can see all of their research. Neurosym's page, really like it. They have the graphs, especially how it shows how it reduces inflammation, and that's using their device. Same thing with Alpha Stim. It has, very effectiveness for anxiety and insomnia and those kinds of things. So, if you find you start with the vagus nerve massage points, on the face, around the ears, you can go with your throat, deep breathing, getting your diaphragm involved. There's so many out there now. And if you're finding some relief with those exercises, but you want something longer lasting, then I would say the device would be 100% worth it. Definitely wouldn't need a medication with it. And you would, do it daily, till you start feeling really good. And then you can do it as needed after that, with the Neurosym, I believe is using it daily for 30 days is where the research has shown like the effectiveness for depression and anxiety. And they also did like long COVID studies and different studies, to show the lowering inflammation and depression in those patients, which are a very difficult cohort, for providers to work with because their depression tends to be so severe. But anyway, and then the Alpha Stim has studies on insomnia, anxiety, and depression. And with theirs, I believe it's 3 days a week minimum, that you want to do it, but daily is where you get the most benefit. And then, you do that for a month or two. And then after that, once you get the benefit, you can just do it as needed to help relieve anxiety or to help if it's insomnia, doing it at night for insomnia. But definitely, like I said, look into that. Could be worth it for generalized anxiety disorder. So those are the things. Therapy. Find a therapist who specializes in, using things like acceptance and commitment therapy uses components of mindfulness and even uses components of CBT. Someone who maybe just does CBT or mindfulness-based CBT could be very helpful, with helping with this type of brain retraining that needs to occur. And then working within the body, because, oftentimes generalized anxiety disorder, we find out, is rooted in some childhood traumas that we never really thought were traumas. Maybe we were yelled at a lot when we were kids. Maybe someone neglected us and wasn't there for us a lot. Maybe you had, two parents working, were left to your own devices. Those types of things can cause trauma and cause a nervous system dysregulation, which are oftentimes overlooked. So working on vagus nerve and working on body work, the somatic work could also be helpful, like yoga. I was talking about that on the question about complex PTSD, but yoga for anxiety, yoga for trauma, very, very helpful because it has a mindfulness component to it as well. And then you're really like exploring your body and what's going on in your body, which is the mindfulness piece, and helps to get you out of that, future or past, and gets you into the here and now. And over time, you'll find definite benefits from that. So I'm hoping that you explore those options and that they're helpful for you. Psychiatric research. Hello. Hi, madam. I had developed derealization after rapid taper of Klonopin. Oh, yeah. It was 3 months period, and I supposed to reinstate Klonopin again. My derealization is still there. What I do with derealization, definitely part of that bind piece that I talk about in that video, benzo-induced neurological dysfunction. So this is what I'm talking about when I'm talking about these effects of benzodiazepines, and Klonopin and Xanax are the two worst ones when we're talking about this. And they're I see the high risk for it, but it can happen with any benzo. But I'm just saying, like, what I see, Klonopin and Xanax worse. So when you do the reinstatement, oftentimes this is what happens. People, they will reinstate because it's so bad. And then they say, I want to reinstate and then try again. So if you reinstated, and then hopefully when you reinstated, you went slowly back up, because that's important, instead of jumping up to a dose right away, because that can, make things a bit worse. So anyway, you slowly reinstated, and now you're back to whatever, let's say it's a milligram. Okay, let's just, for, whatever, let's say it's a milligram, and you're back up to your milligram a day. And hopefully, it's divided, because Klonopin should be divided into at least 2 doses. So what you can do is wait. Okay, that's what I typically would always recommend, is let's wait this out once you're at the dose that you were, before, things went to crap, or, when things were going well. All right, let's say that dose is 1 milligram. And so now we're waiting for the nervous system to get back online and kind of be like, okay, we're used to this now. Like, okay. So when I say wait, 4 to 6 weeks, it's a good time period. Some people want to wait a little longer. I've had patients, because they really don't want to go higher, because they're looking at this, once you've been down this path, you start looking at the medication as poison and as something that's bad for you, which I also caution, because that can change your mindset from a healing mindset to your body not taking a lot longer to heal. So it's really important that you're not thinking of it like this. But that creates this fear of like, I really don't want to go up, but, past the one, like for instance, going from 1 to like 1.2 or 1.25, if you're not doing a liquid and you're depending on the pills, which I would say, hopefully you end up compounding and doing liquids. You can go a lot slower and follow the Maudsley deprescribing guidelines. They have several tapers. I would recommend doing the slowest taper, which does require liquid. But anyhow, so that you could do one of 2 things: wait, and like I said, I've had patients that waited, to 3 months, and they did normalize, and then they're like, I'm glad I didn't go up another one. They feel comfortable, and then they start going down, and we work on their mindset and how they're looking at, the benzo itself. Like, how are you thinking about this? Are you thinking every time you put it in your mouth that it's poison? Because that's going to affect how you heal. So you need to really be careful with that. But anyhow, so like I was saying, like 4 to 6 weeks stabilization. If we don't reach that and you want to try, I have seen someone stabilize in 3 months. So that could be something. If not, then you may need to go up. Okay, which I know is not the ideal thing. And you're probably like, what do you mean? I just want to get off this stuff. I understand that. But if you're not ready to continue a taper, which if you're in this state of derealization, that's pretty significant, nervous system dysregulation and limbic system, dysregulation, then I would say, well, you wouldn't be wanting to taper either. So you have this option of either continue on and wait another 4 to 6 weeks and keep waiting and seeing if you get any relief, or you go up to find that relief and stabilize, stay there for 4 to 6 weeks and then embark on a very, very slow taper. However, I have to say, once you are in this state, which is like this benzo-induced neurological dysfunction, okay, and you do find stabilization, let's say it's 1.5 is where you find stabilization, and you start to taper, you definitely have to go super slow. I think his slowest one is 2 or 2.5% with Klonopin. I think it might be 2%. And when he's doing his reductions, and I'm talking about the Maudsley Deprescribing Guide, when he's doing those reductions, he's looking at receptor occupancy, not dose reduction. So it's a little different. So you could do that, but you may have to even go slower than that. And I would recommend even going slower than that, just because you're high risk. You're high risk for this happening again. You're high risk for it taking a very long time. Like, meaning that definitely not 3 months. Like, I'm looking at, for someone like you, years, and you have to be okay with that. And you have to be okay with tapering, needing to taper over years, and even be okay with having to wait for months on a step, on a stage, as you're going down. Something else that you could do. So I gave you 2 options. You stay and wait and wait and wait, or you go up, right? Those are 2. There is a third option. I will caution though. The third option is switch to Valium. It's longer acting. I caution it because when you're already in the benzo-induced, this bind state, and you try to transition over to Valium, it tends to not work well. And you tend to be more, because Valium has that side effect of like causing more sedation, which what I've been seeing in injured patients who have the bind, it's that it really manifests as like depression and suicidal ideation and those types of things. So I say that so you have to be careful, with it. Though I have seen Valium, the transition to Valium work. It's just that because when it doesn't work, it becomes harder then, because now you got to go back to Klonopin, and then you have to go definitely back up after that. It's hard to stabilize someone after that type of a switch, and then because you're going from one to another, which, if you haven't heard of this term, can cause kindling effect, which is like now you need more to basically treat the issue, because your neuroreceptors are just really like, it's like a brain on fire type of a thing, this bind. And but then it becomes like a paradoxical thing, like where even getting you back on the Klonopin, you're like, oh, like I feel like it's making me now worse, and it's not really like helping. It's just, kindling the fire. It's making it worse, making the inflammation worse. And now you're reacting. And so oftentimes, you will find that you have inflammation markers, you have high inflammation markers. And like I was saying too before, with someone who was talking about starting a taper, when you're already in this state, I still think it's beneficial to look at root causes. I still think it's beneficial to look at nutrient deficiencies and things of that nature. But when you start replacing, know that we're not going to see miraculous things, and that you could be very sensitive to a lot of the supplements, particularly the B vitamins. Like I said, omega-3s tend to be very benign, and can help with brain inflammation. So if you do an omega check and you see your omega-3s are super low, definitely omega-3s are going to be helpful, and high potency, high dosing. And you can do a liquid omega-3s, and if you're cautious, and just slowly get yourself up to that high dose. And magnesium tends to be very gentle. And oftentimes, even if your magnesium is quote unquote normal, it's probably not optimal. But even if it is, you could benefit from it because your body's going through stress coming off of in this state. So your body it has a higher need for magnesium. Um, but definitely looking at those root causes, I would say, and making sure that you are, as your body allows you to, replenishing your nutrient needs and leveraging nutrition and some dietary supplements, even, short term. It doesn't have to be a long term thing with supplements. And oftentimes it's not necessary long term. And then your diet can sustain you afterwards, but when you're in this state, you definitely need a lot more support in that way. Um, which reminds me too, with this derealization piece, like I was talking about the stimulation, right? Alpha stim. So I have patients who, and that's the one that clips on both ears, and it's giving you microcurrents, the alpha stim aid. Very helpful because that's in the vagus nerve. So I use the vagus nerve stimulation device for patients who have this anxiety state, right? Whether it's from benzos or not, or whether it's from, say, antidepressant withdrawal, right? But what I'm finding is it's super helpful for someone with just anxiety. I mean, they find robust effects. But what I've been finding recently is, because I was afraid to start trying it on patients with, these types of injuries, protracted withdrawal or withdrawal states, whether it's benzos or antidepressants, because I thought, well, maybe, it would affect them negatively because we're in the nervous system. And I don't know why. I just was, I didn't really use it on them. I hesitated. But then I started, because I was like, you know what? I found that they were able to use the vagus nerve stimulation around their face and, around their ears and find benefit. And I'm like, you know what? We can leverage this and do the alpha stim and get the, stronger activation of vagus nerve. We can help get them out of these types of states. And that has been very, very helpful in getting the parasympathetic back online, because when you're in this derealization, your limbic system, your sympathetic nervous system, everything's like out of regulation. So we need to get you in to regulation. So you're in like a dysregulated state. We need to get you in a regulated state, and vagus nerve, super, super helpful here. And I've been finding that time and time again, patients finding benefit from the alpha stimate, like I was saying, I use in my office. And it's like after the first treatment, they just, wow, I feel really good. Never felt that. And then they continue it at home, continued improvements, and then it helps them to taper. Like they'll get stuck on, I had someone stuck on 0.25 she's doing alpha stim, and now it's like, you know what, I feel good enough to, like, let's start now. And she's stuck on that 0.25 for a while. I want to say it was over a year. I have to go back and look at my notes to get the exact time frame, but I knew it was a long time. Might have been even longer than that. She's stuck at 0.25. And so, the fact that she's now, boom, tapering and, getting benefit is a testament to something like that. And that's just working on getting her online with vagus nerve. Now I do want to say with her, the nutrient stuff first, and we did replete, I want to say it was omegas. It might've been omegas and magnesium, maybe even vitamin D that she was deficient in, and replacing, and then getting everything online. Things just really start to connect. And like I said, the supplements itself and replenishing those nutrients when you're in this type of state isn't the smoking gun like it should be with someone who's not in this state, because the nervous system itself is dysregulated. So doing things to calm the nervous system, like the vagus nerve work, looking into alpha stim aid, seeing if there's a provider in your area that can let you try it for free. Do like a session where you can try it in office. That's what I offer. And I'm in Vero Beach is where the office is in Florida. So I'd let you, have a session. We could, do a free session with the vagus nerve to see if it'll help you. But anyway, if that's not available to you, you can try the massage points on vagus nerve. And then the other stuff too, like the somatic work, I can't overemphasize that because you need grounding. So doing the mindfulness work in this, like with yoga, Um, it's hard to just sit and do mindful work when you're in derealization. So more of the grounding stuff, like yoga's a lot of grounding with mindfulness, um, getting outside and being more present with your environment, what's around you. Oftentimes people think grounding of being barefoot outside. That's not necessarily what grounding is. So that's like a type of grounding, with energy. But I'm talking about grounding as far as like getting yourself present in your environment, looking at what are, 5 things that you see, 4 things that you can touch, what are some 3 things that you hear, um, 2 things that you can smell, 1 thing you can taste, or you know what I mean? Like just really getting in tune with your senses and grounding yourself back to the here and now. Because with derealization, you really kind of are stepping outside of yourself. And that can be scary, very scary, and can cause a lot of fear. And then of course, cycles into more and more anxiety. So, yeah, definitely utilizing those types of techniques, vagus nerve, looking at your nutrients, replenishing those. Of course, staying away from inflammatory standard American diet. Please stay away from that. And hopefully, if you can start incorporating exercise, start gentle yoga, stretching, walking, things like that. Just to get your nervous system back online. That's what you need here. And then those other things, like I said, either hold, like your options, holding, going up, switching to Valium, but definitely incorporating these other things, especially if you're going to be holding. You gotta definitely leverage to get through the derealization, because it can absolutely precipitate a heightened fear and anxiety state. So I know that was very lengthy in the description and all that, but I think it's necessary. And I think people need to hear that there is this negative side to these benzos and this injury state, which is very, I have to say, very difficult as a provider to watch my patients go through. It's very difficult. So, but those are the tools. Those are the things that you can do to help get some relief. Tan Jun Hang, hello. In what circumstances does a patient require ECT? Well, not okay. ECT isn't a requirement, it's an option. Okay. And it's an option that you need to take with caution. And so when the conversation of ECT comes up, which is electroconvulsive therapy for people who don't know what ECT means, it usually comes up with someone who's labeled treatment resistant and has tried multiple medications. Maybe they're on 4 or 5 different medications and they're just flat. Nothing's working. They've hit this wall. That's when the conversations for things like ECT and TMS start to come up. And that's when, if you're looking at like an algorithm, I guess you could say, is when, conventional psychiatry will say medication, try SSRIs and SNRIs and tricyclics, and then add adjuncts, bupropion adjunct, antidepressants, some anxiolytics, now they're not sleeping. Let's try this. Let's try that. They just keep adding and adding. There's this whole algorithm. And then at the very bottom, it would be like ECT, right? None of this is working. Well, when I look at someone who's considering something like ECT, I want to emphasize to them, did you try all of the things, right, that I talk about? Did you try, of course, I'm hoping if you're considering ECT, you've already done the therapy route. And hopefully you tried that first before medication. Because when you get into the state, it's hard for therapy to be helpful. So therapy first is always a good rule of thumb, and that's in the algorithm, therapy first. But oftentimes not talked about much, and so a pill is given first. But anyway, then looking at nutritional markers, again, for deficiencies, looking at ruling out those medical causes, or, hyperthyroidism, hypothyroid, Hashimoto's, autoimmune conditions, iron overload, right? The one guy I just talked to yesterday, that's top of mind now. I can't believe it. And he's going to feel so much better once he starts his treatments for that. And I'm excited for him. But anyway, yeah, so there are things that could be going on and could be missed, even if you had, "Well, I just had labs done." Take a look at those labs, get a copy. I bet you it's CBC, CMP, maybe TSH, which is not enough to analyze thyroid. So people always say that to me, "Well, I have my thyroid checked." And then I say, "Can I see a copy of your labs?" And it's a TSH. And I'm like, that's not doing anything by itself. We need to look at this with other markers. T3, free T4, for example. And thyroid globulin, thyroid peroxidase, TPO. Yeah, looking at all of those markers together to assess thyroid function and assess autoimmunity. So yeah, I'd be looking at those. The basic labs for mental health video that I did goes over like where I start, and then go from there as far as before doing this. And the reason I say that is because ECT more so than TMS, like TMS could be, and for some people they prefer to do something like TMS, because it's not as invasive as, well, ECT, I guess nowadays they do sedate you. But yeah, so TMS is not really like invasive like that, but it doesn't have like the negative like association with amnesia and those kinds of things that can actually be long-term memory impairments that can happen with ECT. So some people will prefer to do something like that, even before medication. But like I said, I would look at all of the nutrient markers and all, because like I said, even the guy that I just called yesterday with the iron overload, he was considering TMS because nothing was working. Everything was making him feel worse. And it's iron overload. Simple fix. So yeah, I think that we have to make sure that we're diving deep and we're looking at root causes. We're looking at them thoroughly, and we're asking these questions of what can be going on before doing these more invasive type treatments, because there are risks. Yes, it's no medication. And I have to also say this about ECT. I've had patients that have done ECT and now they're not on medication. They're just in therapy. So I had two, well, this is when I was working in community health too, community mental health, that did it, far apart from each other. But anyway, and now I'm doing really well. And then I had one where she was going to do it, but I don't know if she ever did, because I ended up not working with her and kind of doing my own thing anyway. But I know it was a recommendation, and she's working with another psychiatrist, and she was thinking about doing it. So I don't know if she's gotten benefit or not. But I have seen the benefit side of it. Then I've also seen people who have done it and then they end up having more problems, like feeling like they're more depressed, and then they end up going to stuff like ketamine, and then now their memory is really even bad because ketamine, I'm talking about the infusions of ketamine, and so then they're really flat when they come to see me, and then we start, and it takes a slow process at that point to replenish and get the new benefits from nutrients, because we do find deficiencies, and then I'm starting to taper some of them. I have a couple that are like that kind of been down the road of all of the things, meaning all the medications, ECT. I had one do TMS, then ECT, then ketamine, or was it ketamine? Then I don't know, but she did all of them. And we're tapering her now. She's doing really well. But anyway, it takes time. It takes a lot of time. So I would say before thinking of ECT, make sure you've done your due diligence and looked at all of these other things that could be going on before embarking on something like that. But there really isn't like, it's a requirement to do ECT. It's an option. It's not something you have to do. It's an option that's out there. Okay, we'll take a couple more questions. We're coming up on 2 hours. So Sina Desi, if depression is over, but changed to bipolar depression, okay, is it preferable to use the mood stabilizer carbamazepine only? Tegretol, yeah, carbamazepine. So carbamazepine is a mood stabilizer that is iffy on whether or not it's going to treat a bipolar depression. It's mixed. The evidence is mixed. It is in the algorithm when we're looking at conventional medicine to treat. But like I said, the evidence is mixed. And as far as the bipolar, it also depends on the type. So 1 versus 2. So I would say like carbamazepine would probably, if it's going to be helpful, be more helpful with a bipolar 2 than a 1, though I have seen it be helpful in 1, but oftentimes it's needed to be an adjunct with something a little bit stronger in bipolar 1. And when I say stronger, I mean like an antipsychotic. So by itself, like I said, evidence is mixed. I guess it would depend on your severity. And something that has shown a little with bipolar depression per se, a little more evidence would be like a lamotrigine if you're looking at just a mood stabilizer, and definitely bipolar 2. But some people can't tolerate that because they have something with their HLA1, like a histamine. They have more susceptibility to that skin reaction with lamotrigine. So that's something to consider. But yeah, you can stabilize with Tegretol or carbamazepine. But is it something that can be used as only? That's a toss-up. Now, you may be thinking, what about an antidepressant? Well, sometimes, like I mentioned last live with Muhammad, he had asked a question about cyclothymia and adding an antidepressant. So with something like cyclothymia or bipolar 2, mania, like full-blown mania, isn't as high of a risk as someone in bipolar 1 depression. So you can leverage an antidepressant in small dosing to help someone in a bipolar 2 or cyclothymia, kind of help get them out of that depression state. But by and large, when you're looking at standards of practice with bipolar 1, you want to stay away from antidepressants because the risk of switching to mania is really high. So that's where you can start with a mood stabilizer, and if you're doing great, stay there. Oftentimes what will happen with bipolar 1 is that, except for like lithium on its own can be really helpful. But some people can't tolerate lithium. And then we talked about that earlier, the long-term effects of lithium, like the lithium carbonate, because with bipolar 1, you end up needing high dosing of lithium carbonate. Usually typically end up with an antipsychotic and, looking at that. So if I were going to consider like someone who, starting with a mood stabilizer, like after I've done, like I've talked about, I've exhausted what I do already. I don't want to, get on that soapbox again. But, if I've exhausted my options and someone with bipolar, with the nutrients, we've replenished, we've done a lot of the other work, vagus nerve, and really doing all this stuff. And now we're realizing that medication is going to have to be part of the plan. And I often will start with the mood stabilizer versus an antipsychotic just because of less long-term effect issues, particularly metabolic syndrome and those types of things, and EPS. So yeah, maybe carbamazepine could be helpful, but if I then needed to go a different route and I did have to go stronger with like an antipsychotic, I would look into Latuda, lurasidone, less incidence of metabolic syndrome and weight gain, particularly weight gain, though long-term can still have that risk of the metabolic syndrome we have to watch out for, but lower than the others. Vraylar, definitely. With Vraylar, I would be cautious with the restlessness and akathisia, but I have seen Vraylar really help bipolar depression big time. Especially bipolar 1 depression is what I'm talking about here. And like I said, I've seen that really help. So that could be very helpful. So yeah, definitely, keeping that in mind, that mood stabilizers only can be helpful. Super cautious with antidepressants, but sometimes you have to switch to an antipsychotic, or some providers will just add an antipsychotic if the mood stabilizer in and of itself is not effective by itself. And so when you're looking at adding those, looking at the newer antipsychotics, if you're going to go that route, that have a lesser incidence of these long-term effects of metabolic syndrome and weight gain and things of that nature, but still having to do it with caution and whatnot. So I will be taking one more question. We are over the 2 hours, but I'll take one more. But I do want to note that we are noting down. Raul is amazing at he's typing away and getting on a whole other sheet all of your questions that haven't been answered, and so he will have that ready for me at the end of the live stream, and then I'll answer a few of those questions in my newsletter, just to kind of, so that you guys are getting your questions answered. Not all of them, but, especially if I see a group of questions that are similar, I like to put them together and then send it out in a newsletter. So make sure you're signed up for that newsletter, levelheadedmind.com. You can sign up at the bottom. There may even be a pop-up that comes up to, have you sign up for it, but I can't remember if it does or not. Anyway, but yeah, definitely, sign up there so we can get, try to get some of these other questions answered. Cause I know, with time, I am here for 2 hours, but it's never enough, right? Cause more people come in and then they have their questions. All right. So we'll have one more question. And it's Matt Madden. Hello, Matt. Can 5 milligrams of Lexapro be effective? Yes, it can. Okay. So this is a point in case where, if you've been here listening to me talk about the way that I work and do replace the nutrients and things like that, this is where I find, like, just starting someone on low dose while we're investigating and looking, and then we find stuff and we start replacing, you never have to go up. A case in point too, I want to mention too, it's someone who's doing this, not Lexapro, but I think he's still on 12.5 of sertraline, never had to go to 25 milligrams. Amazing. So doing all these things, learning skills, like putting these things in place that I teach in the videos, and replenishing your nutrients, looking at root causes, what could be going on underneath, doing the therapy work, etc. You may need the antidepressant, but oftentimes short term. And yes, 5 milligrams can be very, very effective for people. And then it's a lot easier to come off of at that point, because you never went up and became neuroadapted and then came down, need to come down. And like I said, when I'm working with patients like this, I had one who was actually on Lexapro, 5 milligrams. And we added in some Seroquel. He had some significant insomnia and paranoia going on. And I want to say we got up to 25 or maybe even 50 of Seroquel, and we added in Lexapro. But anyway, long story short, at the 6-month marker, we were able to come off of both of them fairly easily. And he's fine. He's great. And his was mainly anxiety and had some depression, but it was mainly anxiety focused symptoms. And he never, 5 milligrams of Lexapro is what worked for him, and of course that was with the Seroquel, but then we got rid of Seroquel first. I want to say we got rid of Seroquel at the 3-month mark because he was sleeping really good. And then, I want to say it was, and then we started reducing. And then by 3 months, he was completely off. And then we stayed on just Lexapro for another 3 months and then started tapering. That is what I want to say. But yeah, definitely can be effective. Like I said, replenishing your nutrients while you're, will definitely allow for this type of phenomenon to happen, because conventional providers will be like, what do you mean? You're only on 5? That's not therapeutic. Well, yeah, that's because you've replaced everything and you've got your cycle going, and you're able to now make the neurotransmitters better. And then guess what? Eventually not need it at all. So yeah, the other scenario where very low dose could be effective, and even a half a dose of a lowest dose could be effective, would be where if you are a slow metabolizer, say of CYP3A4, that's a genetic thing that you can look for. Super low doses are going to be effective for someone like that, for sure. So yeah, definitely multiple scenarios where low doses can be effective for people. And there's nothing wrong with that. If you are on a low dose and it's effective, hopefully your provider's not pressuring you to be on a therapeutic dose, because that can get you into trouble. And like I said, just replenish your nutrients and do all the things, and consider coming off in 6 months. You're gonna be better off for it. So definitely talk to your provider about those things. So that's it as far as questions go. Like I said, we'll have them. I'll be answering them in the newsletter. I want to thank all of you for being here. I want to thank all of you for being a part of this live, and for all of the wonderful questions. You really get me, get my thinking cap going, and definitely keep me on my toes for sure. And I really appreciate doing these sessions. Oh, I forgot to mention the next live is going to be June 15th. That's the third week in June there. June 15th is when we're going to be doing our next public live. We will have a members only live in 2 weeks. So that is going to be June 1st, I think. Yeah. June 1st. So we'll have the next public live then. And then, members only live June 1st, and then the public live June 15th. So mark your calendars. And if you're not already a member, consider being a member. It's only $4.99. You'll get lives, you get answers to your questions. And then once we start getting more members, we're going to start doing interaction one-on-one. Like Zoom type calls. Right now, I'm just doing the members live, and we are interacting that way. I'm helping to answer questions that I see from members only specifically. So you get a little more attention from me, and it's a little more one-on-one there for just $4.99 a month. So anyway, thank you all again, and I look forward to seeing you guys next time. Bye.